Hi, my name's Hilali. I'm comms lead for Notch, and I'm here today to introduce you to one of the highlights of the symposium. So we've got Professor Anthony Chalmers from the Institute of Cancer Sciences, University of Glasgow. Anthony Chalmers is Chair of Clinical Oncology at the University of Glasgow and Director of Cancer Research UK RadNet Centre of Excellence for Radiotherapy Research in Glasgow. In addition to his neuro-oncology clinical practice at the Bateson, he leads Translational Radiation Biology Laboratory in the Institute for Cancer Sciences and is chief investigator of a series of early phase clinical trials in glioblastoma and mesothelioma. His research aims to improve outcomes for cancer patients by combining radiotherapy with molecular targeted drugs, with particular focus on inhibitors of DNA damage response. From 2016 to 2019, he was chair of the NCRI's Clinical and Translational Radiotherapy Research Forum, or CTRAD, and was founding chair of the UK Radiotherapy Drug Combinations Consortium, or RADCOM, and the Scottish Radiotherapy Research Forum, SCORF. He is a board member of the European Association of Neuro-Oncology, or EANO, sits on the Radiobiology Committee of the European Society for Radiation Oncology, or ESTRO, and led successful bids for Glasgow to host ESTRO 2023 and EANO 2024. In 2020, he was appointed to the Medical Research Council's Molecular and Cellular Medicine Board. So I want to welcome Professor Anthony Chalmers.
Well, thank you very much indeed for that introduction. It's a real pleasure to be here today, and I'm looking forward to this session. I can see that it's a relatively exclusive group. I think there's 14 of us at the moment. So please feel free to chip in with questions as I go through, but there will certainly be time at the end for discussion, and I hope that you will feel able to ask anything, however simple or basic it might be, or however complicated it might be. Hopefully this is a nice supportive environment for asking questions. So I'm hoping now that you can all see my screen. Could you just confirm that you can see my slides, Hilali?
Yes, we can see your slides.
Yeah, brilliant. Thank you. So this is the title I've been given. What are the specific challenges of conducting radiotherapy trials and how can I get involved? I thought I would broaden that title out a little bit. So I'm going to speak a bit more generally about research for clinical oncologists. And rather than just go through a list of challenges, which can get a little bit depressing, I thought I would start off by taking you through my research story and what motivated me to get involved in research and why I still do it and still enjoy it. So this is really the reason. This is the group of patients that I treat, patients with glioblastoma, which, as I'm sure you know, is the most common primary brain tumor. It's an extremely aggressive and infiltrative tumor. It does affect people of all ages, including children and very elderly people. And the current life expectancy for patients with this tumor, if we look across the board, is absolutely abysmal at around 6 months. So neurosurgery is a key part of treatment for GBM, and the techniques that the neurosurgeons use to try to obtain extensive resection of these tumors are getting very sophisticated with the use of 5-ALA, which enables surgeons to visualize tumor cells during the operation, and often coupling that up with awake craniotomy to make sure that they're not resecting crucial eloquent parts of the brain. But despite these exciting advances, which have made a difference to survival, it's really never possible to completely resect these tumors. And therefore, there is an important need for non-surgical therapy. And of those, radiotherapy is the most important and the most effective treatment. Important not to forget that. But it is only partially effective. It isn't curative, unfortunately. So despite improvements in our technical delivery of radiotherapy and our ability to avoid giving high doses to normal brain regions, we still aren't curing any of these patients. And also, an important fact is that the dose of radiotherapy that we can safely give to these tumors is quite significantly limited by the risk of causing delayed and permanent neurotoxicity, which causes cognitive impairment and can be absolutely devastating. And this is a rather extreme example, but this is a patient of ours who had chemoradiation after a good resection of a GBM, age 64, did very well in terms of the tumor. There's no sign of tumor recurrence, but this patient, who was completely well at the time of diagnosis, at this point was demented and in a nursing home. And we can only assume that the radiotherapy contributed to this rapid brain atrophy. We know that adding temozolomide chemotherapy does improve survival for some patients, those with MGMT promoter methylation predominantly. But even despite this advance, outcomes are still terrible. And what these survival curves don't show is what these patients have to go through during their disease course, and also what their families and friends and carers also experience. And I'm really putting this up there because this is what continues to motivate me to stay in research, even when times can be difficult, and what is really the absolute incentive for me to recommend for you all to consider a career in research. So really, this is what my professional life's work is aimed to do, to increase life expectancy of patients with GBM by increasing the beneficial effects of radiotherapy without exacerbating the side effects. And in more recent years, I've become interested in looking at ways that perhaps we could even protect the healthy brain. And I think it helps to have a clear idea of what your mission is in life, but certainly this is something that's evolved over time, and it definitely wasn't something that I came into oncology with. It's something that has evolved. And really, the only way to do this or achieve this goal is by doing research. We can contribute a lot to our individual patients by looking after them well, making sure they get the best treatment and supporting them. But unless we develop and test new treatments, we're not going to improve outcomes across the board. So how have I been approaching this? Well, basically, as you all know, radiotherapy predominantly kills cells by damaging DNA. And it's the unrepaired double-strand breaks that are capable of killing cells, either through induction of apoptosis, as shown on the right, or probably more commonly in GBM cells, by causing mitotic catastrophe, so cells continuing to divide without having repaired their double-strand breaks properly, which then causes a mitotic catastrophe. Why don't we get better outcomes? Well, it's because these tumor cells are capable of repairing that damaged DNA. And there are two crucial pathways to consider: the base excision repair pathway, which repairs single-stranded DNA breaks, and the double-stranded DNA repair pathway, the major part of which is non-homologous end joining, and that repairs about 80 to 90% of double-strand breaks in human cells. So we know a lot about these pathways, and a lot of this work was actually done in UK laboratories. And because of that, we've got drugs that we can use to target them and inhibit their function. So in single-strand break repair, we can inhibit that by using PARP inhibitors. And in double-strand break repair, we can inhibit that, for example, by using a DNA PK inhibitor. So which of these have the most potential in the treatment of GBM? Well, certainly if we inhibit double-strand break repair, we cause a very marked increase in radiosensitivity. But this is probably not tumor-specific. This is going to increase the ability of radiotherapy to kill all the cells within the irradiated volume. And this is going to lead, we think, to an increased risk of brain toxicity. So how can we get tumor specificity? Well, one of the major differences between GBM cells and the cells of the normal brain is their proliferation rates. So the GBM cells are often very rapidly proliferating, whereas the cells of the normal brain are really very quiescent. And so if we think about single-strand break repair, we can inhibit this process with PARP inhibitors, or certainly delay it, slow it down. And that's going to have different consequences depending on whether the tumor cells are dividing or not, or sorry, whether the target cells are dividing or not. So in the case of our proliferating tumor cells, what we've found is that those unrepaired single-strand breaks get converted to double-strand breaks while the cells are replicating their DNA. And these replication-associated double-strand breaks are very difficult to repair and quite likely to lead to cell death, often by mitotic catastrophe. In contrast, in non-dividing cells, even in the presence of the PARP inhibitor, because these cells are not replicating their DNA, the cell often finds ways or alternative ways to repair them. And so we really see no increase in cell kill in the laboratory, certainly, when we combine PARP inhibitors with radiation in non-replicating cells. So we would predict that this combination would cause no increase in normal tissue damage. And actually, this hypothesis arose out of experiments in my PhD, which actually went wrong. It's a classic story. So I was working on this concept of low-dose hyperradiosensitivity, which is this minuscule little blip in radiosensitivity that you can observe at very low doses of radiation, which I thought was really fascinating, but was really difficult to study. And I spent many hours, days, and months in the lab plating out hundreds and hundreds of cells and then irradiating them at all these different doses to see what the radiosensitivity was. And usually I found when I added a PARP inhibitor that we got this nice increase in radiosensitivity. But sometimes it wasn't so marked. And eventually I realized that when I'd been lazy and hadn't been splitting my cells often enough and had been allowing them to become more confluent, that was when the effect was diluted. So I tested that specifically by allowing the cells to become confluent before then plating them for the radiosensitivity assay. And indeed, I found that the PARP inhibitors had absolutely no effect on those confluent cells in either of these two different cell lines that I'd been studying. So that was initially viewed as a setback, but turned out to be the major finding of my PhD, and one that I thought could perhaps be translated into clinical use. So after finishing my PhD, which I did at the old Gray Lab at Mount Vernon, I had 1 year left of my specialist training, and during that period I applied for an MRC, Clinician Scientist Fellowship, which I was fortunate enough to get. And that enabled me to move down to this building, the MRC Genome Damage and Stability Centre at the University of Sussex, which was at the same time that the Brighton Sussex Medical School was just being launched, which was quite good timing for me. So I joined the medical school, and this was a fantastic place to do some basic DNA repair research. And during that time, I really worked to verify this hypothesis that PARP inhibitors only cause radiosensitization in replicating cells, and looked into the mechanisms of that and investigated the therapeutic potential. So this was the first publication on which I was the senior author back in 2008. So at this point, I thought we've got to get this into the clinic, and I felt that GBM was the obvious place to take that. But the big issue was at that time, the PARP inhibitors that we had didn't cross the intact blood-brain barrier. And here's some data to support that. So looking at the AstraZeneca PARP inhibitor called olaparib, which had been radiolabeled and given to mice and rats. And you can see that none of the drug whatsoever penetrates the central nervous system, whereas it does get into the liver and the bowel very nicely. So the initial thought was that we couldn't possibly do this in GBM. But I wasn't really happy with that, because we know from MRI scans and lots of other studies that actually the blood-brain barrier is really disrupted in GBM. And you can see that by this contrast agent, which is leaking out into the tumor. So this led to the operatic trial, which was the first clinical trial that I was the lead investigator for. And as well as testing whether we could give olaparib and temozolomide together in recurrent GBM, we also looked at this question of whether olaparib actually gets into the tumor. So this was patients with recurrent GBM. We gave them 4 days worth of olaparib treatment, and then they had a resection of their tumor, and we were able to measure the olaparib concentrations in 3 different samples from the tumor. And in the end, we had about 70 to 80 samples from 27 patients. And essentially we found olaparib in all of them. And the mean concentrations was around 500 nanomolar, although you can see that there's a lot of variation. As part of that, and in response to reviewers' comments, which at the time seemed really unhelpful, we also were able to look at the tumor margin. So the neurosurgeons used 5-ALA guided resections to remove the fluorescing tumor and then took samples from the tumor margins. And to our surprise, we actually found that olaparib was also detected in those tumor margin samples at pretty much the same concentrations as they were in the tumor core. So what was at the time seemed like an inconvenience has actually turned into an area of real interest for me. What determines delivery of drugs to GBM, both the central regions where there is contrast enhancement, but also these tumor margin regions, which are really critical because often the surgeons take away the contrast enhancing lesion, and it's up to us as the radiation oncologists to treat these non-enhancing tumor margin regions. So just showing how research can take you in directions that you didn't initially expect. Just to tell you a bit about the timelines, not wanting to put you off, but my approach to AstraZeneca, you can see, was back in 2008, before olaparib even had a name. It was just a number. And this led to a grant from CRUK, Drug Development Office, in 2009 to perform the operatic trial. The operatic trial was hard work. We eventually got 7 UK centres on board, and recruitment lasted from 2011 all the way through to 2017. We learned a huge amount along the way, which I don't have time to go into, but what in the end we learned was that it was possible to do this really complex and ambitious study in a number of different UK centres and to get really high quality results. And what's even more perhaps depressing is that that work wasn't even actually published until this year for various reasons that, again, I won't go into, but it has been published in a reasonably high impact journal. And I'm pleased to say that it's being noticed. So you can look at your research metrics. And so, for example, this work has been viewed about 1,350 times since its publication. So that's reassuring. And just while I'm at it, one of the nice things about doing research is that from time to time you can check how much your work is being cited and used, for example, on Google Scholar, which is a nice way of tracking what's happening to your research outputs. So this trial then was the springboard, or opened up AstraZeneca to let us do other studies which we'd wanted to do in the first place, which was combine olaparib with radiotherapy. So we started off in elderly patients with GBM, newly diagnosed GBM here. And the phase 1 study was a dose escalation study of olaparib with short course radiotherapy, which completed and enabled us to move on to a randomized phase 2 study, which some of your centers may be participating, which is recruiting reasonably well. It's complex because we have to do molecular testing on these samples prior to randomization because it's only the MGMT unmethylated patients that we're recruiting. At the same time, we're looking in younger patients, and here we are splitting them up into 2 groups, the MGMT unmethylated group who don't benefit from temozolomide, so we can give olaparib daily, and the MGMT methylated group who do need to have temozolomide. But when we give olaparib, as we learned in the operatic trial, we cause an increase in bone marrow toxicity. So that means we have to give it much more cautiously. But by doing these in parallel, we've been able to make progress, particularly in the unmethylated group. So we're now recruiting to a dose expansion cohort. And pleasingly, we've been able to give the full single agent dose of olaparib, so 300 milligrams twice daily, with no observable increase in toxicity, which has been very reassuring. And I'm currently in quite advanced discussions with AstraZeneca about an international randomized phase 3 study in this unmethylated group. So really beginning to pay dividends for all that early work that we did. The MGMT methylated group, we are running into problems with bone marrow toxicity, so we're currently giving much lower doses, 100 milligrams twice weekly to that group. One thing that's important to note about research is you don't do it in isolation. And so while we've been doing these studies in GBM, other people around the world have been looking at radiotherapy PARP inhibitor combinations in other tumor types. And this has been really informative. So for example, studies in lung cancer have found that it's only been possible to give olaparib 25 milligrams daily. And this is because of esophageal toxicity. So the esophagus tends to run right through the middle of the volumes for these patients. And the esophageal mucosa is made up of rapidly proliferating cells. So perhaps not surprisingly, olaparib's exacerbating that acute toxicity, hence the low doses that can be given. And the same is true of mucositis in head and neck cancer. And so we have this huge difference in what dose of olaparib we can give depending on the normal tissues that are within or adjacent to our irradiated volume. And what this does is two things really. One is it supports that hypothesis from my PhD that PARP inhibitors really do radiosensitize replicating cells in the normal tissue, but not the non-replicating cells in the brain. But perhaps more importantly, it really helps us to design clinical trials and find the best place to use this particular class of agents. Some sneak previews. Is it working in terms of outcomes? Well, this is the data from our phase 1 dose escalation group in our elderly GBM patients. Median overall survival was just, well, between 10 and 11 months, which doesn't necessarily seem very exciting until you compare it with data from international randomized phase 3 studies. So in this study from 5 years ago, radiotherapy alone had a median survival of just 7.6 months. And even the radiotherapy temozolomide group, it was around 9 months. So yes, these are selected patients in a phase 1 trial, but this is at least reassuring early data. If we go to the younger patients and look at the MGMT unmethylated patients, we have less follow-up, but currently our median overall survival is 14.8 months. And if we look at our cohort 5, which is the group receiving the full dose of olaparib, none of those patients have died as yet, which is encouraging, although we don't yet have very long follow-up data on those patients. So I was saying earlier, and I'll say again later, about one of the really exciting things about being involved in research is getting this brand new data. These are data that nobody has ever seen before. And we've asked a question and we're actually getting a real life data on patients who are receiving these new combinations. And that's really exciting and rewarding. What about the MGMT methylated patients? Well, this has taken quite a bit longer and we don't have full follow-up on some of the patients. But in the first cohort, 4 of our 6 patients have lived over 2 years so far, and they're all still alive. So again, quite encouraging early data. And finally, just to show you again that things can develop from research in unexpected ways, I have a collaboration with colleagues in UCSF and Barcelona looking at a DNA damage response gene expression signature. And we've just looked so far in our Paradigm phase 1 patients. And what we found was a real difference in this gene signature score between the patients with the survival over 10 months and the patients who survived less than 10 months. And we can show that in a Kaplan-Meier curve. It's not statistically significant, but this is a really small group of patients. And the people who've been working on this have been really surprised to see such clear separation of the curves with these very small numbers. So maybe we'll be developing a biomarker to tell us which patients will benefit the most from this PARP inhibitor radiotherapy combination. So I've been talking for half an hour and I haven't really got to the topic, but hopefully set the scene. Why should we participate in research? Well, here are some obvious suggestions. It's a really good way of keeping up to date. If you're doing research in a particular area, you have to be bang up to date because you have to know what other people are working on. what's already been shown, and where are the gaps in our knowledge. It's a really interesting way of broadening your skills. So I've had to start becoming familiar with bioinformatics, which doesn't come naturally to me at all. I learned clinical trial design, all kinds of things that maybe I didn't think would be part of my career when I was in training. I've mentioned that being involved in improving treatments is a massively rewarding process, and one that will continue throughout my whole career, I hope. Doing your own research is really valuable in helping you evaluate other people's research. So when you're reading a paper, when I'm reading a paper now, I've got much better insight into what the shortcomings of research might be, or where somebody's done a really good piece of work that I should really take notice of. And I'll come back to what I think some of the other reasons are a bit later. Now, one of the good things about being a clinical oncologist is that there are all kinds of research avenues open to you. And I would say that we have maybe more opportunities than many other specialties. So within clinical research, obviously you can get involved in clinical trials, and I think all of us should be doing that anyway, but there are lots of radiotherapy related clinical trials, either running or in development, that you could get involved with. And it doesn't just stop with the trial design and the running of the study. There's all kinds of associated research projects that can be bolted onto these studies, which are really exciting and maybe you think would be more suited to your interests or your skills. We also have within technical radiotherapy a whole raft of opportunities around the physics aspects of technical radiotherapy and all the imaging that we use to plan treatment, to monitor its delivery, to monitor response, really exciting areas. And then there's all the laboratory work. You may not have done much work in the lab, but we now in the UK have a network of really strong radiobiology related laboratories who work in research that's associated with radiation, but not limited to it. So increasingly immunotherapy, biological therapies, molecular biology, all of it tying in with our radiotherapy practice. And what I'm increasingly aware of is how all these interact. And so you may start off in a clinical trial for your research, but you may then find a question that you want to ask in a lab, and you end up doing some studies to look at that, or you may get more interested in the imaging that's going along alongside that research study. So massive opportunities, and it really is a good time in the UK now to be exploring those opportunities. Is it worth doing a higher degree? You can be involved in research without doing this. I think probably by being part of today's session, you're probably already interested in this. I certainly think it is. It will certainly enhance your CV, and it may give you the edge when it comes to applying to a consultant post or getting the practice that you want in a particular center. And it certainly broadens your options in terms of where you might be able to work and how competitive you would be. I don't know if that's true, but I know that that one is certainly true, what it was in my case. What about some other reasons beyond those career ones? Well, for me, my PhD was a fantastic time for me because it was a time when I was really getting a little bit burnt out, to be quite honest, with all the clinical work. I'd just done part 2. I'd had to take part 1 twice. And I'd just been working so hard and doing exams for so long that I was a little bit burnt out. And the PhD came at a perfect time for me to take a short break from that. And it was a real change of pace, one that I struggled with initially, I'll be honest with you. So as clinicians, we're used to seeing many patients every day, making decisions, changing people's treatment, having an impact on multiple different things every day. Whereas when you go to research, often you'll spend whole days just reading or at a conference listening to other people's presentations. And that felt really odd to begin with, but actually it was very valuable and I think was something that we should do more of as clinicians. It also gave me an opportunity to investigate something in depth. So even though we've specialized in clinical oncology, we are certainly during our training, we are learning about multiple different tumor types, multiple different treatment modalities. We're still somewhat of a generalist. And doing research really was interesting for me in terms of probing a specific question in real depth. The other thing that I think we lose when we are just working in the clinic is our ability to write. And certainly a big part of research is learning how to write, to communicate effectively, compellingly, to communicate your argument. As I've mentioned, it's a good opportunity for acquiring new skills. And the thing that I still find the most exciting is generating new data and then presenting it to people. And that's something that really you won't get if you're not working in research. This at least used to be a perk of being involved in research. And actually, I would say it's something I've really missed since lockdown, meeting colleagues who've become friends in various exotic or interesting locations around the world. At the moment, you're more likely to become a Zoom expert if you're involved in research, but hopefully we will return to at least some level of international engagement in the near future. And as I've mentioned, that change of pace was a real opportunity to think quite deeply and over a longer period of time about what I actually wanted from my career. And I felt that I hadn't really done that before. I'd just been on this conveyor belt, taking exams, getting experience, going through assessments every year, without really thinking, what is it that I enjoy and what makes me feel fulfilled? And just to finish off this section, don't forget, you're going to be a consultant for a long time, probably around 30 years. And this is an awful long time to be seeing patients day in, day out, doing the same clinics week in, week out. And perhaps this reflects in the high prevalence of burnout that has been documented in clinical oncologists. And interestingly, in this study from 1995, it is a little bit old now, but there was a lower prevalence of burnout in medical oncologists, even though they reported similarly high stress levels. And one of the reasons that's been put forward for that is that actually active involvement in research provides a counterbalance to the demands of a full-time clinical post. And the intellectual stimulation and variety that research brings have been shown to reduce the risk of burnout. And finally, the research that you're doing might actually improve outcomes for patients, not just your patients, but patients all over the world, potentially. To get back to the specific question I was asked, and I'm going to do that very quickly so that we've got time for discussion at the end. What are the specific challenges of conducting radiotherapy trials? Well, these are covered pretty much in this paper from Clinical Oncology. So this was an initiative from CTRAD, which I'll tell you a bit more about in a moment. So looking at radiotherapy trial setup in the UK, identifying inefficiencies and potential solutions. And I'd recommend you to have a look at this because it really covers this topic really nicely. And I'd like to point out that at least 3 of the authors on this, Catherine Hanna, Dee Linsky, and Sally Appleyard, are all, or were at the time, SPRs who got involved in this project and actually did a substantial part of the work and the writing of the paper. What did they find? Well, the first thing they found was that if they looked across the radiotherapy trials portfolio, the time to opening the trial from the awarding of the funding, which is day 0, was really a long time. And there was really a need to improve this. So up to really 2 years in many cases. And although it was the trials with minimal complexity of radiotherapy that opened the quickest, beyond that, it wasn't just the complex radiotherapy that was slowing things down. There were all kinds of other issues involved. One of the really important things that they found was that most departments in the UK have insufficient support for getting trials open. So trials radiographers, most centers had between 0 and 1 research radiographer covering the whole trials portfolio. Similarly, for physicists, either none or less than 1 whole-time equivalent helping with the radiotherapy trials QA. Very few data managers for radiotherapy trials, and very few research nurses. So this has been very helpful because it's given us ammunition to ask for more resources. And I think, and you can see that there are some centers where the workforce is much better supported now. And beyond these obvious aspects, they identified a number of themes, one of which was this lack of dedicated resources, but also interesting things like establishing and maintaining relationships and communication with key individuals and organizations, and a lack of previous experience of researchers. And this is really important. Now, I think your generation of SPRs, we really want you to be research literate. We want you to understand what's involved in setting up a trial, so that when you become a consultant or before then, you can come to a center with some experience and help get this done more quickly, rather than everyone starting from scratch every time they try to set up a new trial. So how should you get involved in clinical trials? Well, these are some really obvious things that I think it's worth saying. So let your colleagues know that you're interested in research. I think you may assume that people know, or you may feel somewhat inhibited from telling people about it, but I would say or suggest that every time you start a new rotation, you tell your consultants that you're interested in research. They may not have any projects, but they may be able to put you in touch with somebody who does. And you won't want a project from every rotation. So even if only 2 or 3 of them turn out, then that will still be worth it. I think it's really important to speak to the SPRs who are currently doing research projects. How did they get that opportunity? Are they enjoying it? Who's been helpful? And really important to find out what trials are open in your center. And I'm going to talk a bit later about a new scheme which will help SPRs get approved roles within clinical trials. Now, obviously, a trial will be in a certain tumor type, and you'll be rotating through different tumor types. And we've got to get away from this idea that you can only contribute to a trial while you're on that specialty, because trials take place over years, not months. So I think it's really nice to have the opportunity to be associated with a trial for a sustained period of time during your training rotation. And this is a really important point, and I would really encourage you to do this, to contact people whose work you admire. You may see them at a conference, you may read the paper. It probably hasn't occurred to you to email them and tell them that you admire their work and ask them for guidance or advice, or whether they have any opportunities. They will be absolutely delighted to hear from you. I can absolutely guarantee it. So don't hold back from that kind of thing. Talking a bit now about the national infrastructure for radiotherapy research, which you can use to help you. One is CTRAD. So just to give a bit of background about CTRAD, if we go back 15, 20 years, radiotherapy research in the UK was really in a dire state. There were very few active researchers, and it had a poor reputation. So there was a review, and there was investment in the Oxford Institute, and then a later review. And then it was realized that just having one well-supported institute wasn't sufficient, and there needed to be a national network. So that's when CTRAD was launched. So this is the Clinical and Translational Radiotherapy Research Working Group. And this is the latest vision of CTRAD, which is to maximize quantity and quality of life for patients receiving radiotherapy by optimizing tumor control and minimizing toxicity. And there are 5 main aims, of which the 2 most relevant to today are this one, building the radiotherapy research workforce. So this is one of the things that we're trying to do through events like this and multiple others, to get more trainees involved who maybe will become part of our radiotherapy research workforce. And the other one is changing practice through a portfolio of innovative and collaborative clinical trials. So what does CTRAD look like? Well, it has an executive group, and then it has these 4 work streams, going from basic science through early phase clinical trials, phase 3 trials, including trial methodology, and then work stream 4, covers new technologies, physics, and QA. And over the years, a number of additional working groups have emerged, including proton beam strategy group, academic workforce development, as I've mentioned. We have strong links with the radiotherapy trials quality assurance group, which is a fantastic resource in the UK, which provides funded resource for doing and overseeing all the radiotherapy trials quality assurance in all the centres across the UK. So this has been a really successful initiative, and it's also had fantastic public and patient involvement. And I would argue that some of the initiatives that the CT-RAD PPI group have done have really led the way for PPI in other cancer domains. So CT-RAD has a very multidisciplinary membership. The majority, or about half, are clinical oncologists. We have quite a lot of physicists, some radiographers, radiologists, scientists, statisticians, trial managers, consumers, and even a couple of brave medical oncologists within our membership. Importantly, a couple of years ago, we opened up a new type of membership, which didn't involve being a workstream member, but gave members access to other resources in CT-RAD and also opportunities to participate in particular projects outside of the work streams. And so I would really encourage you to consider becoming a CT-RAD member. It's very, very easy. You just have to submit a short application, which you'll find on the website here. It doesn't cost anything, and it will help you, I hope, to feel part of our UK radiotherapy research community. One of the things that CT-RAD does is support people who want to develop radiotherapy trials. And so we have usually annual clinical trials education workshops. So learning about how trials are developed, funded, and executed. Other events which are more about developing specific trial proposals in specific areas, for example, radiotherapy immune checkpoint combinations, or radiotherapy DNA repair inhibitor combinations, or sometimes tumor site specific sessions. And arising out of these come the ideas for clinical trials, and then a sort of pipeline for trial proposal development. And there's two main ways that works. One is through submission of ideas to RADCAS, which is part of the CT-RAD workstream 3, and they'll give you feedback by email. But perhaps more usefully are twice yearly proposals guidance meetings. So here people come to present their idea to a panel of experts and consumers, and will get really detailed feedback on that proposal and advice on how to maximize their chance of getting it funded. So when we reviewed this in 2017, CT-RAD had by this time already reviewed 208 clinical trials proposals. They get rated at these. So green obviously is ready for funding submission. 99 is amber is needs more work. Red is needs a lot of work, or perhaps there is a flaw with the proposal itself. And white is when something's preliminary, too preliminary really to be fully assessed. So you can see that this is the spread of the ratings. And back in 2017, 62 of those proposals had gone on to be funded. And then just to finish off, a brand new scheme that I referred to previously, and this is long overdue. So the NIHR has created this Associate Principal Investigator scheme. So it's been piloted by the Royal College of Surgeons, and that pilot went well. So now it's been widened and includes partnership with the Royal College of Radiologists. And essentially it enables a junior doctor or other healthcare professional to be recognized for making a significant contribution to the delivery of a clinical trial. They need to be involved for at least 6 months. And if they do that, they'll get a certificate, and they'll also get acknowledgement in the publications. So it's a fairly straightforward process, and the website here tells you how to do it. So I've actually just been through this for 2 of my trials, and it does work pretty well. And I'll be looking forward to getting 2 of my SPRs involved in this way. So this is a really nice way to enable you to get involved, even if you're not doing an MD or a PhD. So this is my final slide. It is complicated to get a trial set up. It can be challenging to participate in research, but I think the rewards are considerable. I would advise you to get involved and seek advice as soon as you possibly can. This is a slightly cheeky comment. I am aware that the exams that you have to do at intervals through your training are a barrier, certainly a psychological barrier to getting involved in research. Oh, I'll wait till after part 1, or I'll wait till after part 2. Oh, I'm suddenly CCT, I've missed it. I would say, please try to get involved in research in parallel with your preparation for your exams and your training. It is possible, and I think it will really enrich your training. And finally, just to reiterate that radiotherapy research in the UK is booming. So now is a really good time to get involved. Okay, I will finish there. I'll be delighted to answer any questions that you have.
Thank you very much for that great talk, Prof. Chalmers. So we do have a question to start off with from Gerald Walls. We're happy for Jared to ask it in person if he wishes, but he's thanking you for the talk, and he says that he's...
yeah, I can read. I know we haven't got much time, so okay. I'll just read that. Right. Was my vision for olaparib with radiotherapy always shared by my supervisors and funding panels? Good question, Gerard. So one thing I would say is that I pretty much did this in isolation, which is one of the reasons that it took so long. It was partly because at the time, the radiotherapy research community in the UK was pretty small. So there weren't many mentors and champions around. And the second was that I was working in this excellent DNA repair lab down in Sussex, but there was no link with the clinic. So again, there was locally nobody to really advise me. And so that was if I had my time again, I wouldn't have done that. I'd have found some champion somewhere else to help me. So I would say that it wasn't shared by my supervisors, and that led to problems getting the research funded. And that's why it took so long. And the way to avoid that, I think, is to make sure either in your center to have a champion, a mentor, and if they don't exist in your center, look outside your center and you will find them. We're a really close community, very keen to help, not just in our own centers. So I think that's an important message there. I don't know, Jared, if you want to follow up on that at all.
Hi, can you hear me, Prof.
Yeah.
Chalmers?
Yes.
Great, that answered my question perfectly. I suppose just as my own PhD experience has developed over the last year, I've sort of seen my ideas conflict with some of my supervisors, and it's just sort of knowing how much should I spearhead my own view on things versus just doing what you're told or what's expected, sort of thing, you know. So that's really interesting to hear that you basically had no one to really to bond with on that.
So that's an interesting angle on it. So in one way, not having much in the way of supervision was an advantage because I didn't have anybody stopping me from doing anything. And I think you have raised an important point. You know, if your ideas conflict with your supervisor, that can be more difficult. So I think that's another situation to look for mentorship and advice from outside your own center. And really everybody should have mentors from outside their center for exactly this kind of situation. And yes, you need to find a balance whereby you're respectful to your supervisor and you listen to what they say. But if you get advice that, you know, it's reasonable to diverge from them on something, then I think it's important that you do that and are supported to do it.
That's great. Thanks so much.
Cheers.
I suppose, Prof. Chalmers, one of the advantages of things like Notch is that actually it's maybe a quick way for trainees to find trainees that are doing similar things elsewhere in the country and sort of gain that support via that mechanism that hasn't necessarily been there before as well. We haven't really explored previously, but might be a really nice way of sort of uniting what everybody's doing and making that avenue available as well.
No, absolutely. And I haven't really covered it in today's talk because I kind of thought the whole day was about it anyway. But I think Notch is a fabulous development. And it's something that we really haven't had anything like before. And I know that SPRs in Clinonc who've been doing research have often felt quite isolated because there was not many of them. So I think Notch is fantastic for that on two levels. One, we're about to be chucked to the main room.
But
keen to carry on this discussion.
Yeah, thanks so much.
Hi guys, as we all start to come back into the main rooms, just to let you know that I've got to do a bit of some whirring on my keyboard because half of you are switching streams. So I'll need 3 to 5 minutes to do that. So just grab yourself a cup of tea, nip to the loo, and we'll be right back after a very brief intermission. We've got Pippa Corrie, who's going to be talking to us about writing for publications in Stream 1, and Dr. Rebecca Lee about research projects and how to get started in Stream 2. So great second session ahead of us, and we'll be right back. Thanks.